AIIMS 2020 Psychiatry for the June exam. It has 6 direct questions from psychiatry. So the question number 1, as you can see, in Viva, the examiner asked a student who discovered EEG and the student said, I don't know. The examiner felt bad and decided to give him a hint and said it has something which is found in McDonald's. The student was able to recall. What type of memory is this? The options given, as you can see, priming, implicit memory, associated learning, and semantic memory. So the answer is priming. So this is the probably trickiest question for this AIIMS exam. So before going for the answer, we will briefly like to discuss the cues and followed by a brief discussion of memory and what you must know for the coming exams. The cues are given: who discovered EEG, which will be definitely a name, over which the student couldn't recollect. So the examiner decided to give him a hint. So examiner does not give the direct answer, he gives a hint to help the student to recollect the name or the fact. And he says it has something which is found in McDonald's. EG has nothing to do with McDonald's, but the answers or the name probably is related. So here you can see the examiner gives a different context, but the names were probably somewhere similar, over which he was helping the student to get his answer. So with this, the student was able to recall with the hint. So here, the recall with the hint is the most important part where confusion might arise. So let's discuss briefly about memory. So this chart is very important. So this is the classification of memory along with types of memory and most importantly the anatomy of memory. As you know, memory is a very important chapter or topic, I will say, both for medicine or neurology and psychiatry as well, and the related anatomy which can come anytime and previously has come in multiple exams which you need to know by heart. So I'll just briefly discuss the divisions of memory, how scientists or researchers divide memory along with the related anatomy and the names. So memory is divided, as you know, as per length of storage, the short term and long term memory. Followed by long term memory can be divided implicit and explicit, and short term memory is always explicit. The names you need to remember are: under explicit memory, it comes episodic memory or semantic memory. Under implicit memory, it comes simple classical conditioning, procedural memory, and priming. Short-term memory is always explicit, which works for working memory, and the related anatomical structure is prefrontal cortex. So, about memory, you just need to remember what is explicit and what is implicit memory, which is based on the awareness. So, the explicit memory happens with conscious try, and the implicit memory is a kind of, you can say, automatic process. I won't go details of every kind of memory, but just remember the names under explicit memory, which is episodic memory and semantic memory. What will come under episodic memory and what will come under semantic memory, that I'll be discussing in following slides. And implicit memory, as we discussed, it is could be simple classical conditioning, procedural memory, and priming. So here mostly I tried to put emphasis over the anatomy. Remember the anatomical location for each kind of memory by heart, as multiple times repeatedly the same kind of questions has come, and Here you need to remember the anatomical locations are quite nearer. So the giving all the options is very easy to confuse the student in the exam scenario. As you can see, all the names and all the anatomical structures are quite close to or adjacent to each other, and suppose for any specific memory, be it episodic memory, if they gives all the four options which are actually related to some kind of memory, the things might get difficult. So I'll start with short-term memory and a little explanation so that you can remember the anatomy. Like if you think brain in a 3D structure or 3D picture, the more inside it goes, the more long term it turns and it stays with the memory. So for short term memory, you can see it is the prefrontal cortex. Outside cortex, rather outside the frontal lobe, the prefrontal area just below your forehead is responsible for short term memory. You can think of a situation like if somebody is telling something that will directly enter in your brain, which is the frontal area, and the prefrontal cortex processes or takes the information for the time being, which is helping a person to do a task or complete a work. So working memory and short-term memory is related to prefrontal cortex, followed by explicit and implicit memory, which comes under long-term memory. So explicit memory, as you can see, first the memory will be remain explicit with active and conscious try, it will be there in the memory. So it has not processed till then. So you can think of a anatomical location of medial temporal lobe and inferior and lateral temporal lobe for episodic and semantic memory respectively. So once the information goes deep into your brain, you can think first the medial temporal lobe, followed by it is going further deep, that is inferior and lateral temporal lobe for semantic memory. To remember about implicit memory, remember simple classical conditioning can happen through autonomic or motoric part. The motoric part, as you know, is always related to cerebellum. The motor activity is related to cerebellum. Autonomic activity is related to amygdala and limbic system. Procedural memory is related to basal ganglia and cerebellum, and priming. Coming to priming, ultimately, it is cortical sensory association areas. I will request you to remember this cortical sensory association areas as remembering the anatomical location retrogradely can help you to revisit the concept in your mind and write the correct answer. So as you can see, cortical sensory association areas. So now the memory has become cortical. It has been spread to cortex. So memory is no more attached to a single location of brain. Rather, it has turned generalized, or you can say the brain areas, the broader part of brain area is remembering it, which is priming. So priming, coming to the our question, what is priming? Priming is a phenomena whereby exposure to one stimulus influences a response to a subsequent stimulus. So let's understand this word by word. So it's a phenomena whereby exposure to one stimulus influences a response to a subsequent stimulus. So if we can think of our given question or the given situation, when the student could not answer about who is the discoverer of EEG, one stimulus or given which is something related to McDonald's. So this stimulus influences a response. Here influences or helps the student to recall a response to a subsequent stimulus which has already been given was the question, who discovered the EEG. So you need to remember there is a trick here. Here the examiner or the exam has actually given the hint or wanted to know from us what is the process of recall or what is the process of subconscious recall. So you can see here no direct name or cue was given, but an associated cue was given. So if we go by the definition given by Turlwing, who is the actual proposer of priming, so he says priming refers to an improvement or change in the identification, production, or classification of a stimulus as a result of a prior encounter with the same or related stimulus. So let's understand this. With the given cue, the student can be able to recollect it. So if no prior exposure would have happened, no question of recall would have happened as well. So with the hint, the student improved his answer of identification or production, I will say, the identification of the name which was in his brain. So here you need to remember the fact of who discovered EG is not priming. It will come under semantic memory. But the answer, if the student would have given in the first occasion, the perfect answer here would be semantic memory. But the student could not answer on the first occasion. He needed a hint which helped him to recall the information from his brain, which happened almost automatically. So then it's go to priming. Clear? So I'll just give a different example. The word nurse is recognized more quickly following the word doctor than following the word bread. Very easy to understand. So if you say doctor, then nurse, or if you say doctor and then ask who are the other health care workers, then nurse comes very frequently. Remember, priming works most effectively when the two stimuli are in the same modality. Between semantic and or in the given example, you can see between semantically related words like doctor and nurse. So again, here the confusion probably would have arisen in many of you. So the words doctor, nurse are semantically related. So if I ask you who are the prominent healthcare workers, then it will come doctor and nurse in your mind, and that is a semantic memory. You know the fact. Few things to remember for future exams for priming. Priming is typically defined as non-conscious or implicit form of memory. As we have already seen in the chart, priming is an implicit form of memory. So priming works for amnesia, like here the student was not been able to recall the name for some moments, which over cues or over priming process came to his mind. So amnesia, what is amnesia? Is loss of memories, facts, information or experiences. As you can see here, it was loss of facts. About semantic memory. So you can see the declarative memory or the explicit memory, which is can be inspected consciously, which could be episodic or semantic. So episodes is always for personal events. So this might get confused in exams, as we have seen. These two names often creates confusion. So episodic is for personal events. Remember, personally we remember the episodes we go through, not about the world, but our personal event are the episodes for ourselves. And semantic memory is memory for general knowledge and facts. Also to remember, episodic memory could be autobiographical or experimental, and flashbulb memory comes under episodic memory. Move over the psychiatric question 2. What is Which of the following is not included in synucleopathies? So they have given a pathological condition, or you can say microscopic finding of synucleopathy, and given options are multisystem atrophy, Lewy body dementia, Parkinson's disease, Alzheimer's disease. So here the answer is D, Alzheimer's. So we'll discuss what is synucleopathy and what you need to remember about it. So synucleopathies are the deposition of synucleons, which are majorly of three types. So remember, synucleopathy is of three types, which is Parkinson's disease, number 2 dementia with Lewy bodies, and number 3 multiple system atrophy. So these are the three types of synucleopathy which is classified under neuropathology. All are alpha synucleopathies. So you need to remember the deposition of synucleons are alpha synucleopathies for all these three conditions. So what is synucleopathies? So it is neurodegenerative diseases characterized by abnormal accumulation of alpha synucleons aggregates in neurons, nerve fibers, or glial cells. So three places are there where the alpha synucleons can accumulate: neuron, nerve fiber, and glial cells. So what happens in Alzheimer's disease? So Alzheimer's disease is beta amyloid plaques. So there it was synucleons. Here in Alzheimer's it is beta amyloid plaques. So quickly to brush up the neuropathology of Alzheimer's disease. So it is NFT or neurofibrillary tangles, so which is tangles composed of paired helical filaments known as neurofibrillary tangles. So they contain an aberrant hyperphosphorylated fibrillary protein known as tau. So here you remember Alzheimer's is a tauopathy. Parkinson's, dementia with Lewy body, and MSA was synucleopathy, and Alzheimer comes under tauopathy. Next question, psychiatric question number 3. So I'll read the question little fast to save your time. Is a known chronic alcoholic who used to drink 2 bottles of whiskey daily now is not consuming for last 2 days, presents to OPD with symptoms of anxiety, hypertension, discomfort, and he is seeing snakes on the floor and no seizure. Which of the following treatment is to be given to control the symptom immediately? So here you get a clinical presentation from which you need to think of, or you need to come to a conclusion about diagnosis followed by the treatment of it. So it's a kind of two-step question. So the options given are A. Lorazepam plus thiamine, B. Haloperidol plus thiamine, C. Lorazepam IV, D. Haloperidol IV. So you can see the options are close like always, and here the examiner tried to assess about your knowledge or expertise, which one to prefer in between lorazepam and haloperidol, that is a benzodiazepine and a antipsychotic, and whether thiamine is needed or not. So little complicated to see, but we will see the answer. So the answer is lorazepam plus thiamine, that is A. So what are the cues? Let's discuss the cues and understand the question first. So the patient is a known chronic alcoholic who used to drink 2 bottles of whiskey daily. So this is a quite big amount. Somebody who is drinking 2 bottles of whiskey daily is clearly dependent on alcohol. Now, for some reason, the patient is not consuming for last 2 days. So here the cue is, after a heavy intake of alcohol, sudden stoppage of alcohol for 2 days, and presents to OPD with symptoms of lot of physical and psychological symptom, as you can see mentioned in the question: anxiety, hypertension, discomfort. So some autonomic arousal, some psychic component also, and the last line is also very important: he is seeing snakes on floors with no seizure. So there is some abnormality of perception, that is hallucination, here visual hallucination, but no seizure is happening. So before addressing this question, I'll just briefly discuss what are the classification as per ICD-10 which you need to remember for this question and to understand this question. So ICD-10 divides the mental and behavioral disorder of any kind of substance into multiple categories and subcategories. So for any kind of substance, it could be withdrawal state, simple withdrawal, next withdrawal state with delirium, and next psychotic disorder. So these three are the most prominent. There are other categories and subcategories as well, but I will like to keep the discussion focused over these three, as here confusion might arise about these three states. So clearly the patient is in withdrawal, no doubt about that, but there is no convulsion and there is, you can see, delirium. So it does not goes to the F10.3, alcohol comes in F10. So it does not go to the F10.3, but it comes to the F10.4. So 10.4 is withdrawal state with delirium. Why delirium? There is perceptual disorder, withdrawal is there, and patient is very anxious, and other features of delirium has also been hinted. So even without convulsion, the patient can go to delirium and it can present with delirium and convulsion as well. As we know, the withdrawal state can sometimes turn actually very severe and life-threatening as well, and you must be already thinking in your mind the condition is called, yes, delirium tremens. So we will just briefly discuss about delirium tremens, what we call DT in clinical practice. And here to remember, lot of question has come from DT, even probably in the just previous AIIMS examination. So remember about the complication of delirium tremens. Any one of this can come as MCQs, all except, or as a one option answer. So their seizure, disorientation, hypertension, hyperthermia, altered mental status, global confusion. You can see these all are in the same parameter. Arrhythmia, aspiration pneumonitis, respiratory failure, and death. So remember about the respiratory condition also. Aspiration pneumonitis and respiratory failure can happen in DT. So the risk factors, what are the risk factors of delirium tremens or DT? So a history of DT itself is a risk factor for subsequent details. So what we clinically see and what is very well known, once a patient receives or experiences a delirium tremens, the chance of future delirium tremens goes high further. Prior history of seizure. It could be simple seizure or alcohol withdrawal seizure without the delirium part, seizure of any cause. So once the brain has undergone through any seizure, the chance of DT increases further. So the presence of concurrent illness, that is associated comorbidities. So in the last November 2019 exam, there was a question on DT where the risk factor was given as infection. So you need to remember any concurrent illness with associated comorbidity could be a risk factor for DT, like infection. Prior history of detoxification. So if the person has gone through a detoxification course priorly, so that is also a risk factor for DT. Prolonged period prior to last drink. So before the last drink, if the person is continuously drinking, which is very clearly been said in our given question, then the risk of DT increases. So this is a chart also you need to remember very well for alcohol withdrawal cases. I'll just briefly discuss the points in a chart form. So to remember one line for lifetime, classic sign of alcohol withdrawal is tremulousness or tremor. So tremor is the classic signs of alcohol withdrawal. There are a lot of symptoms can happen in alcohol withdrawal, like sleep disturbance, anxiety, irritability, but tremor is the classic sign. And also a very famous question which keeps on coming, what are the features which happens timely over the last drink? Like if somebody has taken a last drink few hours back or few days back, what are the sequences of the events or physical symptom which arises over time? So remember, first arises is tremor. Always it will come with hand shakiness, as that is the classic sign, so which arises within 6 to 8 hours. So within first 8 hours or one third of the day, you can remember it is tremor. After tremor the psychosis comes. So next, in the span of 8 to 12 hours after tremor, then comes psychosis or hallucination, and 12 to 24 hours, by the end of one day, the chance of seizure comes. So in the day one, always remember, first comes tremor, then comes psychosis, then the chance of seizure. So first some physical symptom, then some neurochemical or you can say psychiatric symptom, then comes neurological symptom, seizure. So in past, repeatedly confusion has been tried to create by the exams to give the option of seizure, whether the seizure comes first or the psychosis comes first. So always remember, P comes first before S, like PQRS. So P is earlier, that is psychosis is earlier within 12 hours. Then comes S, which is seizure in between 12 to 24 hours. And delirium tremens, remember, anytime during the first 72 hours, classically in between 48 to 72 hours. And in the treatment, as you all know, benzodiazepine and thiamine is the treatment of choice or drug of choice, you can say, for delirium tremens. Not to get confused, here psychotic symptom has been mentioned, but for alcohol withdrawal delirium induced psychosis, we need to give benzodiazepine rather than any antipsychotic. So antipsychotic will be a wrong answer. Benzodiazepine always with thiamine is the right answer. So we will move to psychiatric question 4. Next comes to lithium. Lithium is always very important for psychiatric practice and also for your MCQs. So we need to know lithium in details, and this time they have given 2 questions over lithium. So let's first see the question. Patient is on lithium therapy. For which of these clinical symptoms should nurse warn the patient to be careful of? So there are some symptoms they have given and some warning, when the warning should be given. So basically they wanted to know the side effects or the lithium, when the lithium toxicity is happening, or what are the symptoms or features of lithium toxicity. So option A has been given: skin rash, bradycardia, elevated BP, some skin phenomena, some autonomic phenomena. B, palpitation, occipital headache, chest pain, again some neurological and some cardiac phenomena. C, fever, malaise, sore throat, mostly respiratory and generalized symptoms. And option D is ataxia, diarrhea and tinnitus. So here they give options from or signs from neurology and GI. Tinnitus can also happen, as you know, of neurological conditions. So the answer here is D, ataxia, diarrhea or tinnitus. So first you need to understand or you need to remember what are the systems which get involved in lithium toxicity. Then only you can answer this question in the proper fashion. As you can see, GI and neurological symptom has been written in details. So let's see in a simplified manner the same chart. So this chart, I believe, is very important for any upcoming PG entrance exam, and all the parameters, what are how we divide the lithium toxicity, what are the plasma level, and gastrointestinal phenomena and neurological phenomena. So first remember always three division: mild, moderate, severe. So the recent nomenclature says mild to moderate, moderate to severe, and severe. Plasma level you need to remember three cutoff: 1.5, 2 and 2.5. So remember 1.5 to 2, as you can see gastrointestinal and neurological symptoms starts coming. I have here included only the most important ones which are clinically prominent and also favorite for the MCQ exams. For GI symptom, it is vomiting, abdominal pain and dryness of mouth. Clinically, mostly the patient comes or presents with vomiting and abdominal pain. So remember, abdominal pain could be a very well known or very frequent presenting symptom of lithium toxicity. Neurologically, ataxia, as you can see given in the option, dizziness, slurred speech and nystagmus. So the question might come, which of these neurological signs can be seen in lithium toxicity? Remember ataxia and nystagmus, which are very common in clinical practice. Then comes moderate to severe, 2 to 2.5 milli equivalent per liter. So the GI system here will be persistent nausea and vomiting and anorexia. So patient comes with complaint of I don't feel like eating, I am not hungry. Here you can see blurred vision, clonic limb movement, hyperactive deep tendon reflex, convulsion and EEG change. These I have included. Each one of this is very important. Question might come, at what serum level of lithium EEG change will appear? So not in mild to moderate, it's in moderate to severe. And hyperactive DTR, which is very clinically important and well seen in the lithium toxicity. So hyperactive ankle jerk, hyperactive you can say biceps jerks. These are findings of moderate to severe lithium toxicity. And convulsion can appear itself in moderate to severe lithium toxicity. So what happens in severe lithium toxicity? It's very much neurological then. So the lithium has gone to all your brain cells. So generalized convulsion seen in severe lithium toxicity. And here to remember, I have pointed with different color. Renal features comes in severe lithium toxicity, that is oliguria. Question might come, what is seen in severe lithium toxicity? Is it oliguria or polyuria? So always remember it is oliguria and renal failure which happens in severe lithium toxicity, and death might happen as well. Coming to question number 5. This is again with lithium, as I just said in the previous slide. The bipolar disorder patient is kept on lithium therapy. As a doctor, when are you going to ask the nurse to get serum lithium levels checked? So, one patient is admitted, or one patient who has come for giving lithium blood sample. So, what instruction we will give to the patient also, or the other healthcare worker staff also, that they wanted to know. So, this is kind of more of clinical question. So, let's see the options. 24 hours after the last dose, 8 hours after the last dose, 12 hours after the last dose, and immediately as soon as the last dose is given. Clear? So here the answer is C, 12 hours after the last dose. So let's discuss about lithium levels. So this has also been come in MCQs in previous years. So this 12 hour after serum level of medication is known as serum trough level. Remember this name, trough level, which has been taken 12 hours after the last dose to come to an equilibrium, or when it will perfectly reflect the body status or the serum status of a particular drug. So by SLE here we mean serum lithium estimation, millimole per liter. So what are the lithium level is needed as per the clinical scenario? The numbers are very close, and you can see it has gone up to 2 digit after decimal. But it is very important as lithium toxicity is very common, and lithium clinically being estimated these narrowly, these closely, and exact number you need to remember. Also, in the clinical scenario, you need to remember, as lithium is used for the acute episode and prophylaxis of bipolar disorder as well, you need to remember what has been asked for, whether it is prophylaxis condition or a acute episode has been informed, where the answers will be different accordingly. So first one, prophylaxis condition, minimum effective plasma level. So by this we mean below which there is no chance of clinical response. So that is zero point 0.4. So 0.4 millimole per liter is must, or you can say minimum effective plasma level for a prophylaxis. Below this, there is almost nil chance of clinically effective prophylaxis, and we need to attain at least 0 0.4 for a proper prophylaxis. So then the next step comes, is 0 0.4 always perfect, or 0 0.4 is absolutely optimal for all the patient? The answer is no. So here this is minimum, they said. Next condition we see, it is again prophylaxis, and the range, this is about optimal range. So as you know, as per different person, the response, the clinical scenario, and all the other factors over which a drug response work, different person will need different serum level. So the optimal range is 0.6 to 1.2. By this we mean it should be in between, preferably it should be in between 0.6 to 1.2. Above 1.2, as we already seen, the chance of toxicity increases. So when the serum level cut rate, so when this serum lithium level is between this range, we can expect a fair chance of prophylaxis for the particular patient. So what happens in episodes, or to prevent a further episode, what should be the serum lithium level? More than 0.75 is protective only against manic symptom. So when the patient is under a manic symptom during an episode, then more than 0.75 is helpful. So they specifically mention is manic symptom and an episode. So for prophylaxis, what will be the effective target range? So from minimum effective plasma level to optimal range, now we come to prophylaxis of effective target range. Within what effective target range we should keep the serum lithium level? The answer is 0.6 to 0.75. So quite close, all the values are quite close, and I know it is very confusing, sometimes very difficult to recall in your exam, but I will say you to remember this 0.75 number, because this is a new inclusion in the, I will say, guidelines, and 0.4, 1.2. So remember, below 0.4 nothing is going to happen, above 1.2 chance of toxicity, and 0.75, more than 0.75 is useful only against manic symptom. Here we will also discuss the other medications whose serum level are very important, especially the mood stabilizer. So serum trough level we see for lithium, valproate and carbamazepine. We will briefly discuss valproate and carbamazepine. So starting with valproate, valproate follows three compartmental model pharmacokinetics. So remember this, among these three mood stabilizer, valproate is the one who follows three compartmental model pharmacokinetics. For the blood level, or the serum level rather, the serum trough level less than 55 milligram per liter is almost equal to placebo. By this we mean, if the serum level is less than 55 milligram per liter, the result is almost like placebo or no result. most response has been seen in more than 94 milligram per liter. So you remember a range of 90 to 100 is the area where the serum valproate level should be for a response. And a new inclusion in the guidelines. So for maintenance phase, like the lithium we just discussed, for the maintenance phase, at least 50 milligram per liter. So the acute episodes or where the patient is going through an episode, it's more than 94, somewhere around 100. And for maintenance phase, it is at least 50 milligram per liter, below which of no use. Next comes carbamazepine. Serum carbamazepine level is also very important because here the therapeutic window is very narrow. So remember the numbers of 4 to 12 milligram per liter. Serum level of 4 to 12 milligram per liter is important for therapeutic range for epilepsy. As you know, carbamazepine is an anti-epileptic drug. So 4 to 12 is an range for anti-epileptic effect, and for affective illness like depression, for bipolar illness, at least 7 mg per liter. So at somewhere around 8 to 12, earlier it was being told 8 to 12, now they have given the number of at least 7 milligram per liter for affective illness. So these three drugs, lithium, valproate and carbamazepine, you can understand is very important for serum level and the most used clinically as well. And lithium is often monitored very strictly in all the centers for all the patients. So remember lithium very importantly and very closely, and along with that the valproate and carbamazepine part 2. Last question, we came to the psychiatric question number 6. So which of the following is an adverse effect of a psychoactive drug that acts as a selective serotonin reuptake inhibitor, or SSRI, as you all know? So they wanted to know the SSRI adverse effect: constipation, dry mouth, blurring of vision and sexual dysfunction. Here the answer is sexual dysfunction. So this is a very common side effect of SSRI, or selective serotonin reuptake. So sexual dysfunction or SD is a very well known and common side effect of SSRIs. Here we just discussed in a little more details what is the effect of SSRIs over the sexual response. So the guideline says, so it is double plus. So effect is quite significant for all the three stages of sexual desire or sex drive, sexual arousal and orgasm. So next time the question might come over the stage. So you need to remember SSRI works significantly over sexual desire or sex drive phase, also in sexual arousal phase, also in orgasm. And also overall this says among all the antidepressants, relatively high rates of sexual dysfunction across the all the SSRIs. So there are multiple SSRIs, as you know, escitalopram, citalopram, sertraline. So over all the SSRIs, the relatively high rates of sexual dysfunction. So what about the other three symptoms? Constipation, dry mouth and blurring of vision. As you know, these are all anticholinergic side effect. So these three, constipation, dry mouth and blurring of vision, these three is a group of anticholinergic side effect of TCA, or tricyclic antidepressant, which is also a other class of antidepressant and quite frequently used. So with this, we finish this discussion. Thank you friends. Hope this video and definitely all the videos of Hippocampus and MedEasy will be helping you. See you soon with further details and further discussion. Thank you.